Welcome to everybody. I know and recognize some of the names. I don't recognize all of the names, and I think it's a great opportunity for us to come together as a Jefferson community. That's really the goal of these presentations. This is the third presentation we've made since the spring. We really learned so much from our COVID experience that we really found that the platform could be used to reinvigorate the Jefferson OB/GYN community. Jeff Spence and a number of people in the Jefferson Office of Institutional Advancement have been really tremendously helpful to the department to try to bring together our medical school alumni who are in OB/GYN, our residency alumni, our faculty alumni as well, to come together and have an educational experience, and to the extent we can, lift a glass and catch up with friends we haven't seen for a while or friends we'd like to make in the future. So that's really the goal this evening, to leverage some of our really superb faculty members and to really try to build or rebuild, reinvigorate the spirit of the department and re-engage our alumni. So tonight we're really excited to have Norm Rosenblum. I think many of, if not most of you, know Norm, who's one of our couple of most senior faculty members in the department. Norman obtained his PhD in anatomy at Jefferson before finishing medical school, went on to train in OB/GYN and in gynecologic oncology at Penn, had a few stops on the road before coming back and joining the department at Jefferson again full-time about 18 years ago, and has really been one of the stalwart clinicians and educators and role models in our department since long before I came to Jefferson in 2011. Norman's topic this evening is surgical anatomy of the female pelvis. I'm going to turn it over to him and just again want to welcome everyone. Hopefully we'll have time for questions and comments, and then for those who might be able and wish to, a remote glass of wine together afterwards. So Norm, you're on. Thank you.
Right. Well, I want to thank you all for being here. I saw some of the faces. I saw people on this line who actually trained me when I was a resident. I saw Mike Horn over there. I mean, I remember when I operated with Bert Wallenbach, he had to sit down because he was having some chest pain, and Mike took over the case. And I was a medical student then, and it was one of my first experiences doing hysterectomy. It was great. So Mike is here, and I see him and some other people. So hopefully we'll get a chance to talk at the end of all this, but it's really great seeing you all. So I'm going to talk about surgical anatomy since that's my interest. And this is very informal. And if anybody wants to interrupt me, go right ahead. All right. And we're going to do this and see if we can go next slide. So I have no disclosures to talk about, except this is my picture from my class when I went to my reunion in 1970, from a class of 78 in 2018 in my fourth reunion. The other pictures with my better half, and I think her brother is somewhere on the line here too, not to embarrass him too much, but I think my tie is a little bit better on this one when my daughter got married, and the glasses aren't as thick either. So here's a little bit shorter. So I want to welcome you all, and I really thank you for all being here tonight. What I want to do now is I'm going to talk initially about the perineum, and we're going to go from the perineum to the pelvis and try to get through this in the next, 45 minutes or so. And if I go over, just stop me. So when I think about the perineum and when we operate vaginally and in the perineum, we think of two triangles. You think of a urogenital triangle and an anal triangle. And I try to tell the residents that whatever goes from inside the body to outside the body has to go through one of these triangles. So the urethra and the vagina go through one triangle, and the rectum with the anus is going to go through the next triangle. So here's the symphysis pubis, the coccyx. What we're sitting on right now, ischial tuberosities, this is the urogenital triangle, and there'll be a urogenital diaphragm, and there'll be this is the anal triangle, through which there'll be a pelvic diaphragm, through which the different structures from inside the pelvis are going to go to the outside, and this will be urethra and the vagina, and this will be the anus. This isn't moving. Oh, here you go. So in the lower abdominal area, we all know that there's skin in the subcutaneous tissue that's campers, and there's a special superficial deep fascia called scarpus fascia. And scarpus fascia is kind of unusual in that it's only in the lower abdominal area from the umbilicus. It attaches to the inguinal ligament, which is from the anterior superior iliac spine to the pubic tubercle, and then attaches to the fascial out of the thigh. And then it forms kind of a cup like an athletic supporter over the perineal body and attaches to the perineal body in this area. This area here is called scarpus fascia. When it goes to the perineum, it's called Colles fascia. It's the same stuff, it just changes its name, and it's going to form the superficial boundary of the superficial perineal space, where there's going to be a lot of stuff in that area, and it's going to have potential space where blood can accumulate in certain situations that stops at the thigh and stops at the umbilicus and goes no further. So here we are. This is skin. This is Camper's fascia. This is Scarpus fascia. And Scarpus then goes over the perineal body to this area. And this is the Colles fascia. This is round ligament going through the inguinal ligament. So this is superficial. This is deep. So if I open up Colles fascia, I'm going to see these structures in the structure aerial here. This white structure here is the inferior fascia of the urogenital diaphragm. So between Colles fascia here and the inferior fascia of the urogenital diaphragm is the superficial perineal space that goes up to the umbilicus, out to the inguinal ligament, and out to the thigh. So it's a potential space. Just for reference, this is fascia out of the thigh. And just remember this small opening here. It's called the fossa ovalis, through which little vessels are going to come out from the femoral system and supply the anterior abdominal wall. And we'll see them in a little bit later. So remember, Colles fascia is here. We open up Colles fascia. This is the inferior fascia urogenital diaphragm and the structures that we're going to discuss in a minute. So again, this is superficial. This is deep. So Colles fascia has been taken off. This is the ischiocavernous muscle, and that's going to cover the crus of the clitoris. This muscle here, can you see me when I'm pointing to the pointing things? Yes.
Yeah, Norm, you use your cursor. There you go. That's better. Yeah.
Okay.
Now we can see it.
Okay, it's on the wrong side. I'm sorry. I'm using this. This is the ischiocavernous muscle covering the crus of the clitoris. This is the bulbar cavernosus muscle covering the bulb of the vestibule. That's this, and the greater vestibular gland. This is the inferior fascia of the urogenital diaphragm. So I'm just going to go back because I'm sorry that this happened. Again, this is skin. Camper's is here. Scarpus is here. This goes down in the pelvis. This is Colles fascia. I open up Colles fascia. This is the inferior fascia of the urogenital diaphragm. All right. I'm sorry that I didn't put the cursor. So again, ischiocavernous muscle covers the crus of the clitoris. This is the bulbar cavernosus muscle, covers the bulb of the vestibule, which is erectile tissue, and the greater vestibular gland, also known as Bartholin's gland. All right. This is the superficial transverse perineal muscle. This is the strided sphincter of the anus. The strided sphincter of the anus controls liquid stool and flatus. So if you're having a cup of coffee and you have to pass gas, you clamp down on this so you don't embarrass yourself. But that's important to know about the different functions of the muscles in this area. Where all these muscles come together, the bulbar cavernosus muscle here, the superficial transverse perineal muscle, and the strided sphincter, external sphincter of the anus, this is the perineal body. So in the old times, when I was trained by the people on this line here, and we did do episiotomies, and we used to build up the perineal body, that's what you did in this area. Also, when you did the husband stitch, you sewed the bulbar cavernosus muscle from here to here. We don't do that anymore. The residents tell me they don't do that anymore. This muscle here is the pelvic diaphragm or the levator ani. So remember, the structure between the Colles fascia and this is the superficial perineal space, There's a superficial perineal space containing the structures that I just mentioned, all right? And this is the transverse superficial perineal muscle. A lot of times when people cut this, they think they cut the external sphincter, but what they're cutting is just this superficial perineal muscle in this area. Is everybody with me on that about the structures? So this is the urogenital triangle through which the urethra and the bladder and the vagina come through. And this is the rectal or anal triangle through which the anus comes through. And this is the levator muscle here. This is the inferior fascia of the urogenital diaphragm. All right. Shake your head, Mike, if that's right. Thanks. So this is the inferior fascia of the urogenital diaphragm, the bulb of the vestibule, which is erectile tissue, and the greater vestibular gland. The reason people have some fear when they want to do resect the Bartholin's gland is it can be very bloody. And the reason why it's bloody is because this structure is here, and this is all erectile tissue. So if I open up the inferior fascia of the urogenital diaphragm, we have the structures in a deep perineal space. This is the urethra and the striated sphincter of the urethra. This is the external sphincter, the striated sphincter, not the smooth muscle, but the striated sphincter. And this is the deep perineal, transverse perineal muscle. So if we're going to do some type of exoneration to either remove the bladder and the urethra or remove the vagina, you have to go through this diaphragm and through these structures. All right, when that happens. So this is the lower abdominal area. This is the skin, subcutaneous tissues. This is Camper's. This is Scarpus. And this is the rectus muscle fascia. The fascia of the rectus muscle, anterior abdominal wall, is in this area. On the right side here, this is the fascia lata of the thigh. In the fascia lata of the thigh, there's going to be an opening. That's called the foraminovalgus. And out of that foraminovalgus are going to be the vessels that supply the anterior abdominal wall from the femoral vasculature. Okay. If I open up this structure here, this is the femoral triangle deep to the fascia lata. This structure here is the inguinal ligament that goes from the anterior superior iliac spine to the pubic tubercle. This is laterally. This is the sartorius muscle or the Taylor's muscle, and medial is the adductor longus muscle. And in the femoral triangle is the famous mnemonic navel that we learned in medical school, right? Femoral nerve, femoral artery, femoral vein. Then there's an empty space, that's the femoral canal, and L for lymphatics or lacunal ligament in this region. In the old days, when I was doing anatomy and before I became an oncologist, we thought about lymph nodes being along the inguinal ligament and along the saphenous vein as being the superficial nodes. And then the deep nodes were medial to the femoral vein. This node, called the Cloquet's node or the node of Rassmuller, this is kind of the first sentinel node we ever learned about because we used to remove this node. If this node was positive, the next step in the trial, in the lymphatic drainage is the pelvis. But right now we know through various dissections and through studies that the majority of lymph nodes in the groin area that we do for vulvar cancer is right where the saphenous vein drains into the femoral vein. All right, that's where most of the nodes are located. So this is superficial and this is deep. All right. We don't do these too often, but back when I trained, this was kind of a standard incision we did for a radical vulvectomy. Now we don't do this anymore. The only time we do this is for necrotizing fasciitis or for somebody that has hidradenitis. This is the right side. This is the inguinal ligament that we repair the hernia here. This is the femoral artery and the femoral vein. And this suture is actually on the saphenous vein. And this muscle here is the adductor longus muscle in this region here. This is the perineal body. Here, the pubic bone is here. This is the crus of the clitoris and the ischiocavernosus muscle that I'm cutting in this area over here. So this is what we used to have many years ago. I'm sure when Dr. Schlaff was a resident, he did this at Michigan a number of times with Dr. Morley. This is the pubic bone over here. This is the cut edge of the ischiocavernosus muscle, and the bulbocavernosus muscle, are gone. And this is the inferior fascia of the urogenital diaphragm. Here's the urethra, here's the vagina, and this is the anus. So this is where the urogenital triangle is and the anal triangle in this area here. And then in the old days, you used to try to put this together under a lot of tension, but now we use advancement flaps and it heals a lot better. So urethra, vagina, coming through the urogenital triangle, and the anus is going to come through the pelvic diaphragm in that area. So now we're going to go to the pelvis. The pelvic bone is made up of two hemipelvis is made up of three bones. This is the ischium is here, and ischial tuberosity. This is the ilium, and this is the pubic bone with the superior and inferior ramus of the pubis. joined in the front here by costal cartilage and civis pubis, and back here at the sacrum, sacroiliac joints, acetabulum. This spine here is the ischial spine. This is the ischial tuberosity. This is the greater sciatic notch. This is the lesser sciatic notch. And we're going to change those sciatic notches into foramina through which things are going to travel out of the pelvis, back in the pelvis, or just back back down into the lower extremities. And this is the acetabulum here. For those, I think Jose Mises is on here, but when you do urogynecology and the proper orientation of the pelvis, the anterior superior spine and the pubic bone are perpendicular to the wall. So the pelvis is kind of tilted anteriorly in the upright position. So when you reposition the vaginal apex, you have to remember this orientation. So this is the pelvic inlet. Here's the anterior superior iliac spine, the pubic tubercle, and the pubic crest. So the inguinal ligament is going to go along this area here. This is the arcuate or the pectineal line. This was the border of where the pelvic inlet is located at. There's a ligament on here called the pectineal ligament, also called Cooper's ligament. And when we used to do Birch procedures, we used to hook a suture to this ligament. Now with all the, the TVTs and the OTs, they don't do that anymore. But we on this line, I know a lot of the people online trained me to do these, and a lot of you did this in practice. When we did the Birch procedure, we would attach a suture for the paraurethral tissue to the Cooper's ligament, which is along this area. I keep on hitting the button, I'm sorry. Also, we know that we used to call the inlet here, above this area was the false pelvis, and below this area was the true pelvis, because all the structures are in the true pelvis, the bladder, the rectum, the uterus, the vagina in that area. And of course, we use the ischial spine when we're saying station, as far as when the baby's head is engaged or not, when the bipyramidal usually passes through the inlet at this area here, which is usually 0 station at the ischial spine. So now this is the side of the pelvis. Remember we had the ischial spine, ischial tuberosities. Well, now I'm going to put these ligaments here. There's a ligament that goes from the spine to the to the sacrum. That's the sacrospinous ligament. And there's a ligament that goes from the sacral tuberosity to the sacrum. That's the sacrotuberous ligament. And things are going to go in and out of these areas. So this is the greater sciatic foramen. This is the lesser sciatic foramen, and the obturator fossa is over here. So there's a large muscle here. That's the obturator internus muscle that goes out the lesser sciatic foramen and goes into the greater trochanter of the hip, and it's a lateral rotator of the hip. This is the piriformis muscle. It goes out the greater sciatic foramen and also attaches to the greater trochanter, another lateral rotator of the hip. So again, the greater sciatic foramen, the lesser sciatic foramen, the obturator internus muscle, the obturator nerve, artery, and vein are going to go out the obturator foramen canal, and we'll see that later. And the greater sciatic foramen is here. Covering the sacrospinous ligament is going to be a muscle, and that's going to be the coccygeus muscle or ischiococcygeusa muscle. And when individuals do a sacrospinous fixation, what they're doing is they're putting a suture through the coccygeus muscle to the sacrospinous ligament. Keep on doing this, I'm sorry. Sacrospinous ligament. You have to be careful because the middle hemorrhoidal rectal artery is going to be coming right along this area here. And there can be some issues if you go too superior and go in the wrong spot. You get some bleeding. And I've been called when people were first starting to do this procedure when they had some bleeding in the pelvis. A little bit tricky stopping that bleeding from the pelvis. So be careful in this area. So again, this is the greater sciatic foramen. This is a lesser sciatic foramen. This is the obturator internus muscle going out the lesser sciatic foramen to the greater trochanter. So there's going to be nerves, arteries, and veins going out the greater sciatic. So the pudendal nerve, artery, and vein are going to go out the greater sciatic foramen and back in the lesser to supply the perineal. This is the ischial spine. So when I was taught and when I did pudendal blocks, you feel for the spine, right? You go inferior medial, and then you inject the local above and below. Again, when you're doing sacrospinous fixations, you have to make sure you stay medial and not laterally, because there's a big nerve, the sciatic nerve from L4-5, S1-2-3, that comes down. Sorry, my fingers. That goes out the greater sciatic foramen and then goes down the back of the leg, which is the largest nerve of the body, to supply the lower extremity. So that's a sciatic nerve, right? 4 or 5, S1-2-3 is a sciatic nerve. Everybody understand with that? Okay, Mike. All right. Ischial spine. That's the only one I can see really. So I appreciate that. So now we're going to look inside the pelvis. All right. So this is the pelvis, and this is the obturator internus muscle that's over here. Now, I like to, in the old days, when I was waxing cars all the time, I also used to put oil in my car, and we used to have this funnel that we used to put in the car to fill oil into the car. All right. So what I want you to believe is that the room that you're sitting in is a big open area like this, and we're going to put a funnel into this space, into this room. It's going to attach to the pelvic sidewall. So this is the obturator internus muscle, and we're going to put this funnel into the pelvis. And this funnel is going to consist of the levator ani muscle, which is made up of the puborectalis muscle, the pubococcygeus, and the iliococcygeus. So these three muscles are going to form the levator ani muscle, and it's going to attach to this obturator internus along a line in this area. This is called the muscle white line, or the arcus tendineus levator ani muscle. So the levator ani muscle, which is the pubococcygeus, the puborectalis, the pubococcygeus, and the iliococcygeus, are going to attach to the pelvic sidewall. These three muscles, the puborectalis, the pubococcygeus, and the iliococcygeus, plus that coccygeus muscle I talked about before, this whole area is the pelvic diaphragm. This white structure over here is the superior fascia of the urogenital diaphragm. So the urethra and the vagina go through the urogenital diaphragm, and the rectum with the anus goes through the pelvic diaphragm. So these are the two diaphragms we talked about at the beginning, about the urogenital triangle and the anal triangle. This is the obturator internus, obturator canal, the muscle white line, the levator ani muscle that includes the puborectalis, the pubococcygeus, and the iliococcygeus make up the levator ani, plus the coccygeus muscle. That's the pelvic diaphragm through which the rectum is going to go through. The urethra and the bladder go through the urogenital triangle. This is real life. This is the rectum here. The bladder is gone, right? So this is the urogenital. This is what the urogenital triangle was located at. That's the urethra, which was removed from below, and this is a pelvic sidewall, and this is the pelvic diaphragm. Urogenital diaphragm was taken out in this area here, and this is the rectum that's still in place. This is the puborectalis muscle, and what's important about the puborectalis muscle is that it pulls the rectum at the junction of the rectum and the anus. It pulls that angle anteriorly. So when you do a rectovaginal examination, your finger goes down and then back up. This muscle, the puborectalis muscle, is for control of solid stool. The striated sphincter of the anus that I showed before in the perineal area is for flatus and liquid stool. This structure is for continence of solid stool. So if you do too vigorous of a posterior repair or vaginal repair, people sometimes can't pass stool through the rectum because this is too tight. And sometimes it has to be released. All right. Also, in infants that have imperforated anuses, the pediatric surgeon will look for this muscle to do a pull-through procedure. That's the puborectalis muscle. Again, repetition. This is the pelvic sidewall. This is the obturator internus muscle. This is the muscle white line. This is the piriformis muscle. This is the urogenital diaphragm through which the urethra and the vagina pass through. This is the rectum here, and the pelvic diaphragm through which the rectum is going through. Vaginally, same thing. Urethra and the vagina going through the urogenital diaphragm, the rectum going through the pelvic diaphragm, and the levator muscle here. And this is the coccygeus muscle. So these muscles, these all incorporate the pelvic diaphragm. Looking at this from a coronal standpoint, to put three dimensionals to this, this is the obturator internus muscle. This is the pelvic diaphragm or the levator muscle. This is the urogenital diaphragm. This is skin here. So the vagina is this area here. So if you're doing a skinning vulvectomy, you just take the skin of the vulva. If you're doing a simple vulvectomy for Paget's disease, you go up to the Colles fascia, which is here. Between here and here, between here and here is the superficial perineal space with the crus of the clitoris, the ischiocavenosus muscle, the bulb of the vestibule, the bulbar cavernosus muscle, and this is the deep transverse perineal muscle. If you have a lateral extension of a vaginal laceration and you see fat coming out, you're here, and that's the ischiorectal fossa, and that's where the pudendal vessels are located at. We all have that experience when we have a bad lateral vaginal laceration during delivery, and there's fat that comes out. That's where you're located at, in this region over here. So this is a live pic. This is an actual picture of a total exoneration. So there's no muscles here, right? The bladder, the vagina, the rectum is completely resected, and all there is some presacral fat in this region. It's been completely resected, both the urogenital diaphragm and the pelvic diaphragm. So if we're in this room here, wherever room you're at, and we're the bladder and the uterus and the vagina, and we have to be connected to the side walls somewhere. So there's specialized fascia that's on the surface of the organs here, the bladder and the uterus, and that's visceral peritoneum. I'm sorry, that's visceral peritoneum. And the visceral peritoneum has to be supported to some way by the parietal peritoneum that's attached to the muscles. So the muscle is the side walls. These sheaths of tissue connect the visceral to the parietal peritoneum to support the various structures of the pelvis. So this blue line you see is a specialized visceral peritoneum that surrounds the bladder, the vagina, and the rectum, and forms a support network for the organs of the pelvis to sit in the pelvis. And this specialized fascia is sometimes known as endopelvic fascia, smooth muscle, collagen in this region. So there has to be a support system for the bladder and for the vagina to kind of be supported. So this blue structure here is that specialized fascia that helps support the pelvic organs. In this area here, it'd be the uterus sacral and the cardinal ligament. And in the area of the bladder and the vagina, it's going to form kind of a trampoline for which the bladder can sit on, and posteriorly where the rectum can sit on. So this is a picture of the pelvis again. This is the obturator internus muscle, and this is that muscle white line of the levator ani, to which the levator ani muscles are connected right here. If I cut the urethra, you'll see this white tissue that's supporting the bladder here and underneath the vagina. So this is that connection between the visceral and the parietal peritoneum that forms a line. And this is called the arcus tendineus fasciae pelvis. If you have a defect in this line here, and you do a vaginal examination and you see a cystocele and there are lateral defects, this is the paravaginal area that Colin Richardson kind of made his career move on when they did the paravaginal repair for lateral cystocele repair in this region. You would put this line back together if there's a separation of the arcus tendineus fasciae pelvis. So this is the muscle white line, and this is the fascial white line. So Delancey, when he's still in Michigan, when we started the program in Michigan about vaginal support, had three different levels that he supported to support the pelvic viscera. So Delancey level 1 is the uterus sacral and cardinal ligament area. So if this Delancey level 1 support goes, you have total vaginal prolapse, uterovaginal prolapse, right? That's what's supporting the uterocervical junction to the structures, to the uterosacral ligament and to the cardinal ligament in this area. Delancey level 2 is that specialized fascia that's between the bladder and the vagina and the rectum and the vagina. So it's like a trampoline. So if there's a defect here in that level, you have a cystocele, correct? If it's lateral, you have the lateral areas, or you have it essentially, you have a centralized cystocele defect. Delancey level 3 is around the urethra and in the perineal body. So it's very interesting that you can completely take off the bladder off this vagina. And we do this with urologists when they're doing a neobladder. But at the level of the urethra is fused with the vagina. So if you have to take out the urethra, you have to take a piece of the vagina out. So again, this is Delancey level 1, Delancey level 2, and Delancey level 3 around the urethra and the perineal body. All right. So if you look in the pelvis laparoscopically, you're going to see these sheaths of tissue that is connecting the pelvic sidewall to the viscera. It forms these sheaths of tissue that go lateral to medially and surround all these structures. And it's going to form potential spaces in the pelvis, and the potential spaces are where we as gynecologic oncologists live retroperitoneally. But also anteriorly on the anterior abdominal wall, when you do a laparoscopic procedure, you're going to see folds of peritoneum. There's going to be a median, MEDIN umbilical fold, and that's going to cover the urachus, which is the remnant of the allantois. No, it's going to be a medial umbilical fold, and that's going to cover the superior vesical artery, is going to be coming up this to cover the remnant of the umbilical artery. So medially, it's going to be the urachus. The median, this is median, this is medial fold, is the obliterated umbilical artery. And then the lateral fold is going to be the epigastric vessels. So when we do laparoscopic procedures, we have the residents look anteriorly to see these 1, 2, 3, 4, 5 folds of the anterior abdominal wall covering these various structures. And you want to make sure you put your trocars lateral to this area. So all these folds make potential spaces. And these are the avascular spaces of the pelvis. There's going to be a space between the pubic bone and the bladder. It's going to be the space serratus, or the retropubic or prevesical space. There'll be a space lateral to the bladder. That'll be the paravesical space. There'll be a space lateral to the rectum between the ureter and the internal iliac. That's going to be the pararectal space. There'll be a space between the bladder and the vagina. That's the vesicovaginal space. There'll be a space between the vagina and the rectum. That's called the rectovaginal space. And a space between the sacrum and the rectum. That's called the retrorectal space. So we have the uterosacral ligaments here and the cardinal ligaments here. So these are the avascular spaces of the pelvis. And these avascular spaces, paravesical space, pararectal space, presacral space, and various structures are going to be along this area for us to identify, including the ureter and the various vessels in the pelvis that we're going to show you now. So this is the right side of the pelvis. This is the common iliac artery, the external iliac artery vein. This is the internal iliac or hypogastric artery, and this is superior vesical artery. This superior vesical artery will continue as the obliterated umbilical artery up on the anterior abdominal wall. Lateral to the superior vesical artery is going to be the paravesical space, and the obturator nerve and vein are going to be over here. We're going to show you that in a minute. And this is going to be the pararectal space between the ureter that's marked by this vessel loop and the internal iliac. This suture here is on the infundibulopelvic pelvic or the ovarian vessels. So I just do that. I use silk suture just if I'm doing a case and it's a long case and I lose orientation. I know where the ovarian vessels are. I always go back there to get oriented to where the pelvis is. This is the paravesical space, and this is the pararectal space. This is the common iliac artery, external iliac artery and vein. This is the hypogastric artery, we'll show later. And this is the ureter on the medial aspect here of the pararectal space. So I find the pararectal space between the internal iliac and the ureter. This is the space between the bladder and the vagina. This is a radical. This is from a pregnant radical hysterectomy that we did. This is the bladder. This is the vaginal apex. This is the vesicovaginal space here. This is the space between the vagina and the rectum. This is the rectovaginal space. The peritoneal fold is way up here, and this is all retroperitoneal. These are the uterosacral ligaments that are cut. Just remember, this ureter used to be over here, and we'll show you that later. But this is the uterosacral ligament backed by the sacrum. This is the pararectal space over here. This space over here is the rectovaginal septum. So you're looking down the rectovaginal septum here. These are the cut uterosacral ligaments. This is a space between the rectum and the vagina. This is the pararectal space. This is the ureter. Again, repetition, but the spaces, the avascular spaces behind the bladder, that's the space of Retzius, so the retropubic space, the vesicovaginal space, the rectovaginal space, the paravesical space, and the pararectal space in this area. And behind the rectum is the retrorectal or the presacral space. You with me, Mike? Smiling. Now we're talking about the vessels, all right? This is the third portion of the duodenum. This is the bifurcation of the aorta. This is the right common iliac artery, the left common iliac artery, and this is Big Blue, AKA the vena cava, right? The ureter is out here. So the aorta is going to bifurcate over the fourth lumbar vertebra, and the umbilicus is usually located in a normal individual over L4 and L5. So we tell residents when they're going to put, if they do a Verres needle placement into the umbilical area, that the table is parallel to the floor, okay, and aim a little bit towards the pelvis. Because as somebody gets heavier, the umbilicus gets lower and lower and lower, okay? But if you, in this area, the most common area for trocar injury, all right, or a Verres needle injury is right here at the left common iliac vein. And that's the most dangerous area we get, where most injuries are going to occur. But this is the common iliac artery here, the common iliac artery on the left side in this region, and this is the ureter out here. What's important to understand is that the ovarian vessels on the right side are going to go into the vena cava and the aorta, and up here real high, the ovarian vessels are going to be lateral to the ureter. But then the ovarian vessels cross the ureter, become more lateral and superior, and the ureter is going to be medial and inferior in this area. On the left side, the ovarian vessels are going, you know that the ovarian vein is going to go into the renal vein, and the artery is going to go into the aorta. The inferior mesenteric artery is going to be below the ovarian vessels in this area, and then the bifurcation of the aorta is in this region. So this is the common iliac artery. This is the external iliac artery. So the external iliac artery is going to give two distal vessels off. One's going to be the inferior epigastric. That's going to go in the posterior rectus sheath, and that's going to go medially, and laterally is going to be the circumflex. The deep circumflex vessels are going to be coming off in this area. And when we do a node dissection, we try not to go further than the deep circumflex vessels, but they'll be medially, and the inferior epigastrics will be coming off on the other side. The external iliac is going to be here. The internal iliac is going to be here. Now, the internal iliac, right when it bifurcates, is going to give off a posterior branch and an anterior branch. The posterior branch only supplies muscular structures. It's going to give off the lateral sacral, which is here, the iliolumbar, and the superior gluteal. So when we do a hypogastric ligation, you want to be 1 centimeter or 2 beyond the bifurcation of the common iliac, because if you don't, you could stop the blood supply posteriorly, and you could have ischemia to the butt, to be honest, in that region. So you want to be careful and go beyond the region of the bifurcation about 1 centimeter or so. So then that gives off the anterior branch of the hypogastric artery, which is the main division that gives off the structures that we always talk about. So the anterior division is going to give off the uterine artery. It's going to give off the superior vesicle. There'll be an inferior vesicle. The inferior vesicle either will be by itself or with the vaginal. There'll be an obturator. There'll be a pudendal. There'll be a middle rectal, and there'll be an inferior gluteal. All right. In this area is going to give all the, and the reason why, if we do a hypogastric ligation in this region, there are about 9 or more collateral anastomoses in this area. So you can keep blood supply to the organs that are in this region. So as I said, there are a lot of collateral circulation in this area. The rectum is supplied by 3 vessels in this area. There'll be a superior rectal, which comes off the IMA. There'll be the middle rectal, which will coming off of the hypogastric directly. And there'll be an inferior rectal that's off the pudendal that's coming up through the perineal area in this region. So in real life, this is the external iliac artery here. There's external iliac artery and vein. This is the deep circumflex that's going to come off here. And the inferior epigastric is going to be coming off of here. But this is a deep circumflex. This is the hypogastric artery, continuing as a superior vesical artery in this region. This is the obturator, the paravesical space. The obturator nerve, artery, and vein are in this area. This is the pararectal area. So if we're going to do a hypogastric ligation, you want to do the ligation down in this area. You don't want to do it real high because the posterior division is going to be coming off in this region. All right. And then all the lymph nodes are going in this area. So you can see see all the vessels now. If you're going to do a hypogastric ligation, we tell the residents that you put your right angle from lateral to medial because you don't want to stick the right angle into the vein. This is really up against this in real life when the nodes are in. And then you just put your suture, you bring it through in this area and tie off the vessel in this region. So you go from lateral to medial, not medial to lateral. What's so important also to identify is when the superior vesical artery comes back, the first branch that's going to go medial is going to be the uterine artery. So if I get into a case where there's some bleeding and I have to control some bleeding, I find the superior vesical artery, I go back medially, and I find the uterine artery that goes over the ureter in this area to get the blood supply at its origin. So that's an important landmark, and I'm going to show you that in a minute to find. So this is a laparoscopic view on the right side of the pelvis. This superior vesical artery, the superior vesical artery comes down here, and the first artery that goes medial is the uterine artery. This is the paravesical space, the pararectal space, and this is the hypogastric here. The obturator nerve is lateral. But just to show you, if you come back on the superior vesical artery, the first one that goes medial is going to be the uterine artery, pararectal space, paravesical space. This is the lateral wall. This is the psoas muscle here. This nerve here is the genitofemoral nerve, which is L1, L2 in this region. This is the common iliac artery. This is the external iliac artery, the internal iliac artery. All right. The genitofemoral nerve is going to be coming on L1, L2. The ilioinguinal is further up, and that's from L1, and it's going to go through the inguinal ligament. We'll see that later. But the genitofemoral nerve is going to come right on top of the psoas muscle. So this is the pelvic sidewall. As you can see, there's no parametrium because this is the retropubic space, or the space of retzius. The paravesical space is connected to pararectal space because the parametrium has been completely taken out in this exenerative specimen. This clamp, that big vessel here with the clip, is the hypogastric that was cut and taken out as part of this resection. This is the obturator nerve here, as you can see, and this is the extrailiac artery and vein. So now we're going to talk about the ureter. We don't usually see the ureter this way, but this is my introduction to the ureter. The ureters are hanging into this big specimen here. This is the ureter, and this is the uterus, the cervix, the bladders on the other side of the vagina, and the parametrium in one specimen. So the ureter is going to have two parts. It's going to have an abdominal part, and it's going to have a pelvic part, and the pelvic part is going to have three parts to it. I'm going to show you that. Remember, I told you the ureter is lateral to the ovarian vessels up in the pelvis, and then the ovarian vein and artery cross it. So in pregnancy, when you have ovarian vein syndrome, the reason why you have a right hydronephrosis is because these vessels get engorged and press on the ureter. Also, you know that the uterus, the pregnant ureter is going to be dextro-rotated. It's going to press on the ureter on this side, and the left side has a sigmoid colon to prevent compression on the ureter. But the ureter is going to come in the pelvis at the bifurcation of the common iliac artery. So here's the pelvic ureter. It's the pars posterior, intermediate, and anterior, the three parts. On the right side, the ureter is going to enter right at the bifurcation of the aorta. On the left side, it's going to be a little bit above the bifurcation. And this is harder to find because the sigmoid colon is sitting here. And the left ureter is going to be more commonly injured than the right when you're doing surgery, especially on the left side of the colon. But the ureter comes down lateral to the uterosacral ligament along the medial leaf of the broad ligament, goes underneath the uterine artery, and then goes into the tunnel, the vesicouterine tunnel, where it sits on top of the edge of the vagina, and then it goes into the bladder. In the old days, when people had women had distal urinary stones, the urologist, when I was a student, I saw this done. The urologist would feel the stone through the vagina, open up the vagina, open up the ureter, take out the stone, and then close the ureter and close the vagina. So the ureter can be damaged in a number of areas in the pelvis that we'll talk about in a minute, but that's the main course of the ureter in this region. So again, the ureter is going to take this course when it's going to go into the pelvis in this region, and where it's going to cross the ovarian vessels, again, the way I demonstrated that before in the other slide. Also, in this area where the vesicouterine ligament is, it's going to be surrounded by a lot of vessels that are from the uterine vessel. When we do a radical hysterectomy, we have to open all this up. And that's where most of the blood loss is when you're doing a radical hysterectomy, when you open the anterior and posterior vesicouterine ligaments in so-called the ureteral tunnel. This is the ureteral tunnel where the ureter travels underneath this tunnel and goes into the bladder in a radical hysterectomy specimen. So this is what it looks like after it's all dissected. This is the ureter here. This is the vagina, and the uterine arteries over here. So the four spots that the ureter can be damaged during a hysterectomy and a BSO, no matter how you do it, is when you take the ovarian vessels of the infundibulopelvic pelvic ligament, when the ureter crosses the uterine vessels cross the ureter in this area, where the uterosacral ligament is taken, and in the vagina. If you have lateral vaginal bleeding in the vagina, if you keep on going lateral, you're going to get the ureter. So those are the four areas where the ureter can be damaged: at the ovarian vessels, uterosacral ligament, where the uterine artery is, and distally in the vagina. And those areas you have to be careful of and make sure the ureter is out of your way. I think that endometriosis can be worse than cancer, because when I get called into bad endometriosis cases, this is the ureter is scarred to the uterosacral ligament, where there's an endometrioma scarred in this area. If you pull on that ovary and don't dissect it, the uterine vessel is here and the ureter. So you have to be careful in this region, just from experience. This is the ureter going into the bladder. So there's no tissue surrounding the ureter here. You can see that. So that's been completely dissected out in this radical hysterectomy. And that's the space between the bladder and the vagina and the rectum and the vagina. Just real quick about, I think I'm okay. We're almost there. Lymph node drainage of the female reproductive tract. The vulva is going to drain to the inguinal lymph nodes first before it goes to the pelvis. Okay. The distal vagina is going to drain the way that the vulva drains. The cervix is going to go to the pelvic nodes and then to the paraortic nodes, and the upper vagina and cervix are going to drain to this area here. The uterus can drain to the pelvic nodes, but also to the paraortic nodes. And in fact, there's about a 7% chance that you can have positive paraortic nodes without the pelvic nodes being involved first. But in cervical cancer, you'll never have a paraortic node positive without the pelvic nodes being positive. And in vulvar cancer, you'll never have a pelvic node positive without the inguinal nodes being positive first. And the ovary can go to the paraortics, it can go to the pelvic, and also to the inguinal lymph nodes, as can the endometrial cancers can go through the round ligament to the inguinal areas. So that's why when people have positive inguinal nodes in endometrial cancer, it's stage 4, and the new staging system for endometrial cancer is stage 3C1 is pelvic nodes, and C32 is paraortic nodes with or without pelvic nodes. But this is the drainage for the female reproductive organs. Finally, in the female reproductive tract, and we talk about the autonomic nervous system, remember the sympathetic and the parasympathetic system. So the parasympathetic system is craniosacral, the sympathetic is thoracolumbar. So there are going to be sensory nerves that are going to come from the female reproductive organs over the sacrum, the sacral promontory, and joining nerves that go back to the lower thoracic and lumbar spine area. And remember, so when I used to do OB and knew something about OB, and we used to do epidurals, when people were in labor initially, and you want to get a level during labor, you just get a T10 level. Well, the T10 level was the umbilicus, because that's where these sympathetic nerves are going back with the sensory nerves back to thoracic lumbar area, right? And then that's going to be the superior hypogastric plexus. So in the days of pre-sacral neurectomies for deep pelvic pain, we used to cut these nerves. Remember that? Do the pre-sacral neurectomies for deep pelvic pain and endometriosis. Had to make sure the ureters were out of the way and then do that. Well, then the nerves go against the pelvic sidewall, and then they're joined by the parasympathetic nerves, which are S2, 3, and 4. And those nerves are then going to go into a uterovaginal plexus, also known as Frankenhausen's plexus. When you do paracervical blocks, it'll have a vesical plexus, and it'll have a middle rectal plexus. So when we do deep pelvic dissection, either the old type 3, very deep radical hysterectomy, or doing low anterior resections, if you go real low in the pelvis, these women are not going to be able to urinate right away because the parasympathetic system that supplies the bladder is going to be affected. So we all know that when we do a very radical surgery, we'll leave the Foley catheter in for several days to let this area kind of calm down. Finally, on the perineal area, there's going to be two different supplies of nerve supply to the sensory area of the vulva and the perineum. Anteriorly is going to be the genitofemoral nerve and the genitofemoral nerve and the ilioinguinal nerve are going to supply anteriorly, and posteriorly is going to be the pudendal nerve and is going to be the posterior femoral nerve. So we're done pretty much, but I got to tell a story just to put some levity in this dull subject. So when I was at HUP, and in the days when we used to deliver babies in a delivery room, gowned and everything, we did a lot of epidurals. So, and you'd be on at night and and we all did, as unfortunately we all did median episiotomies in those days. So I would be left with the patient and the nurse would leave, give me some suture, and I would sew the episiotomy. So I'm with a medical student one night and he delivered about 4 or 5 deliveries with me. And I had to go into another room because they had a precipitous delivery. So I said, look, I'm almost done. Just put a couple sutures over here and we'll be fine. I go in the other room and I'm delivering a baby and I hear this screaming and crashing and I hear the screaming. I go in the other room and there's the medical student on the floor, knocked out cold. And the woman's legs are out of the stirrups. So I go in and we wake him up and whatever. And I said, what's going on? He said, well, Norm, I saw the patient had a tear of her vulva up by the urethra. And I saw earlier today, you just put a stitch in there and everything went fine. So I did the same thing. Well, the patient that he was helping with had a pudendal block. So she was blocked here, but she was alive up here. And so he understood then what the difference of the sensory supply of the vulva is. Yeah, the epidural, the whole thing was numbed. But in this situation with the pudendal, it was just inferiorly. So he learned the hard way about the nerve supply to this area. Well, I think I'm on time, and I know this was a crazy way to go things, and I hope it educated or was helpful in some manner. But this was 1 year ago today, May 13th, 2020, operating in the COVID era, and we took a picture of the group when we were operating and with all the resident team. And this is grand rounds in the COVID with my partner Scott Richard out by the cafeteria. I was drinking a cup of coffee, had my mask off then. But that's where we used to do everything, listening to the grand rounds on COVID. And today I'm happy to hear that we can now take our mask off if we're vaccinated wherever we are. I think the hospital policy may change. And hopefully someday, I hope now it's going to happen, where we can join Gritty, Swoop, and the Fanatic and Franklin at all the sporting events here in Philadelphia. So I thank you very much. And I think I'm on time, 8:01. So I guess we did it. And I hope it wasn't too fast, but they wanted me to get through all this material.